And again, it's sort of part of this whole series where I want to sort of try to demystify some of the head and neck. So what we're going to do is that we're going to first start about the various subsites of the oropharynx. So when you look at the oropharynx, just sort of think at it as a rectangle. So this rectangle extends anteriorly to approximately the level of the circumvallate papilla, then also to include the anterior tonsor pillars. And we're going to talk all about this later, but basically this is our circumvallate papilla here. So the anterior portion of the oropharynx is going to be at the level of the circumvallate papilla. And I'm going to go to my little laser pointer here because it's a little bit easier to see. So this is the circumvallate papilla. And then this area right here is the anterior tonsor pillar. So this is the anterior margin of the oropharynx. Now, the posterior margin of the oropharynx is going to be the posterior pharyngeal wall. So when we look at our triangle right here, this is going to be the back of that posterior pharyngeal wall. Now, the superior aspect of the oropharynx, and this was a little bit interesting. I didn't really understand the confusion until about a couple of months ago on one of the web chats. But for me, I always learned that the superior portion of the oropharynx is where the soft palate abuts the posterior pharyngeal wall when you swallow. So when you swallow, the soft palate is a dynamic structure. So when you swallow this, let's see, someone's on the chat. Can everyone hear me okay? Oh, you can't see the slides?
No, we
Hold on
can
for a
see the
second.
slides. I
Oh, you
think
can't see the slides? Okay.
yeah, we can see the slides and we can hear you absolutely fine.
Okay. All right. So, all right. So you're okay then. Okay. Thanks. Thanks, Akshay. So the interesting thing is that when you swallow, this soft palate is a dynamic structure. So when you swallow, the soft palate abuts the posterior pharyngeal wall. And there's a little ridge right here that's called passivance ridge. So the way that I was trained is that the separation between the nasopharynx and the oropharynx is at the level of passivance ridge. And so when you read some of the anatomic, or I should say the radiological textbooks, not the anatomic textbooks, this passivance ridge is approximated by the hard palate. So if I drew a line from the hard palate all the way to the posterior pharyngeal wall, that's going to tell us where passivance ridge is. Now, the interesting thing is that when you do read other anatomic textbooks, they suggest that the separation between the nasopharynx and the oropharynx is along the superior surface of the soft palate. Now, if you're in a relaxed position, then you can make the argument, well, everything above here is going to be in the nasopharynx. But from my understanding, this is the way that I was taught, 35, 40 years ago, is that the soft palate is a dynamic structure. So the passivance ridge up here is going to be the separation between the oropharynx and the nasopharynx. So as a result, the superior margin is going to be right here at the level of the hard palate. And then the inferior margin is going to be down here about the level of the vallecula. Now, if you really want to be an aficionado, the technical separation between the oropharynx and the hypopharynx is a little fold of tissue right here that runs from the pharynx to the lateral margin of the epiglottis, and that's called the pharyngoepiglottic fold. But that's approximated by the base of the vallecula. So that's sometimes we use the base, the vallecula interchangeably. So those are essentially the margins of what I refer to as, if you will, the rectangle of the oropharynx. Now, there are four primary subsites of the oropharynx. There's the tongue base, there's a soft palate, there's the tonsil, and there's the posterior pharyngeal wall. And we're going to discuss these all in detail. So if you're not familiar with this anatomy of the oropharynx, don't worry about it. And then if by the end of my talk you still don't understand it, don't blame yourself. That just means I've done a terrible job. So I'll do my best to try to make it a little bit easy as much as you can. So the first thing that I'm going to discuss is going to be the embryology, because in this format, the one things that I like about this format is that we have enough time really to do some really fun drill downs. So what I want you to do is understand that when we look at the head and neck area and we talk about the oral tongue and we go all the way down to the larynx, it has different origins from the branchial apparatuses. So the first branchial apparatus is going to form the oral tongue. So when we talk about that fifth nerve, and remember the fifth nerve is supplied by in part sensory from the inferior alveolar nerve. We also have innervation from the 12th nerve for motor, but we also have sensory from the lingual nerve. Those are all branches of the fifth. So if you wonder why that fifth nerve is associated with this, is that embryologically it's formed, it's the first branchial arch, which is going to be associated with the fifth nerve. Now, somewhere down here is a second branchial apparatus, and we know that the nerve for that is the seventh nerve. But when we actually look at the final embryology, notice how this blue kind of disappears. So somewhere the seventh nerve is there, and we know that part of that chorda tympani is coming from the seventh nerve, and we know that this chorda tympani provides sensation and taste for the oral tongue. But in the context of this lecture, what I want you to do is concentrate on the third branchial apparatus, because the third branchial apparatus is innervated by the ninth nerve. So that's the glossopharyngeal nerve. And then also when you come down a little bit lower, when we actually start looking at the vallecula and also the top of the larynx, that's going to be supplied by the 10th nerve. And the reason why I specifically mention this is, number one, you're going to have lots of different innervations to the tongue complex itself, because we know motor is supplied by the 12th cranial nerve. But when we start looking at taste and sensation, it's a combination of the 7th, the 9th, and the 10th. So for the tongue base, it's predominantly the 9th. And if you go down to the epiglottis and the vallecula, it's going to be 10. And the reason that I specifically mention this is one of the things that just I recently learned is that when we talk about otalgia, when we talk about referred pain to the ear, we know that there's lots and lots of causes of otalgia, that painful ear. And we can have a full lecture on otalgia in the future. I'm sure you guys have all seen that. But the point that I want to make is that the eardrum is actually supplied by 4 different cranial nerves. So when you look at the outer margin of the eardrum, it's actually supplied by cranial nerve 5, by cranial nerve 9, and cranial nerve 5, cranial nerve 7, and cranial nerve 10. But when we look at the inner margin of the eardrum, the inner surface of the eardrum, it's actually supplied by cranial nerve 9. So the point is that if you are reading head and neck studies and someone comes with ear pain and you see a neck CT, you always have to make sure that you look at the tongue base and down here near the piriform sinus and the larynx to make sure that you don't have a tumor that's invading the tongue and that's giving you the referred pain to the eardrum that's going to cause the otalgia. So remember, this is the applied embryology. So there's a reason we learn embryology. And part of the reason we learn embryology is that we can take these little tidbits that we learned at one time that we probably forgot. But on the other hand, it really does have substantial clinical applications. So let's begin our journey with the oropharynx. And the first area that we're going to talk about is the tongue base. So as I mentioned before, the oropharynx, a subside of the oropharynx is the tongue base, and that's formed right here by the circumvallate papilla. And this circumvallate papilla looks like a V. And right at the apex of the V right here is our famous foramen cecum. And we're going to talk about the foramen cecum a little bit later and some of the developmental abnormalities that arise from this area. But when we look at the tongue base, we go from the circumvallate papilla posteriorly. So all of this tongue right here, this part of the tongue is the tongue base. And I do want to point out a couple of things. You can see this cobblestone appearance. It's almost like little pebbles right here. Notice the surface of the oral tongue is relatively smooth. But when we get back here to the tongue base, we can see a lot of pebbles and a lot of cobbles. And you'll see later on when we talk about pathology of the oropharynx why that's important. So this is what we see anatomically, I should say on a schematic illustration, and this is a cross-sectional imaging from the Visible Human Project. Now, what I want to point out right here is that the anatomy that we're seeing right here is a combination of the oral tongue and the floor of the mouth. Now, these structures right here, these muscles that run from the genial tubercle and extend posteriorly and attach to the tongue is called the genioglossus muscle. This muscle right here is going to be the hyoglossus muscle. The reason why I specifically mentioned this is that when you look at this anatomic structure and then we look at the CT scan, notice these vertically paired structures. I should say vertically because it's a cross-sectional imaging, but notice how some paired structures and they look like some stripes. When you look at the anatomic image, notice how we have now these transverse fibers that go from right to left. And also look how the muscles are very, very dense with musculature. But look posteriorly, notice these stripes right here. They're going from left to right, and there's a lot of fat. So people oftentimes ask and say, well, if you have a tumor involving the tongue base, how do you know it's actually in the tongue base and not extending anteriorly into the floor of the mouth? And the way that you do this is the following. So here's a CT scan, and we can see the paired structures running from anterior to posterior. But notice the tongue base right here, similar to what we see on the anatomic image. See how it's fat right here? Look at the attenuation right here in the tongue base. See how it's very, very low attenuation? And this indicates a higher fatty content. So if I had a tumor that was right here, isolated the tongue base, I know that's in the tongue base. But all of a sudden, if I see this lesion extending anteriorly and it crosses the junction of the genioglossus muscle and the tongue base, now I know that there is a component in the floor of the mouth. So this is the anatomy and the attenuation characteristics of the tongue base. So this is an example that I was referring to. Here's a schematic illustration involving the right side of the tongue involving the tongue base. And notice we can have these various spread patterns. So these tongue-based cancers can cross the midline, they can extend posteriorly, they can extend laterally, but they can also extend anteriorly. Now, on your right here is an example of a tumor that's primarily arising from the tongue base. But what I want you to do is draw a line down the middle, compare the right side to the left side. When we look at the left side, we can see the low attenuation here involving the tongue base. And then look at the attachment right here of the genioglossus muscle as it attaches to the tongue base. So this is normal on the patient's left side. On the right side, notice this tumor is involving the tongue base, but it's actually extending anteriorly to involve the posterior aspect of the genioglossus muscle. Now, you can make the argument and say, well, how do you know this is a floor mouth cancer as opposed to a tongue-based cancer? How do you identify that? Well, for me, I take a really simplistic approach. If I had to contour this tumor, I would end up contouring the tumor like this. And then I would ask myself, I draw a line down the middle, I compare the right side to the left side, and where would the center be? So for me, the center of the tumor is right here. And when I look at the opposite side, it's actually in the tongue base. So that's how I try to figure out exactly where these tumors are arising from. So that tells me that this is a tongue-based cancer. So now you have to ask yourself that question, why is Dr. Mukherjee going on so long about tongue-based cancers? And the reason is, as I mentioned before, the tongue base is part of the oropharynx. And we know now, and especially in the United States, and I would say is Europe as well too, and I'm not sure about India, but I would venture it's a high percentage as well, is that oropharyngeal carcinomas, the majority in the US, are associated with HPV. So we know about the human papillomavirus. These tumors predominantly, HPV positive tumors are primarily involved with the tongue base, whereas HPV negative tumors are involving other sites, which include the oral cavity. So for those of you that have seen cancers due to chewing or betel nut, those are HPV negative, whereas the HPV positive tumors involving the oral pharynx are going to be predominantly the tongue base and the tonsils. Histologically, they're different. These are more basaloid. They tend to occur in younger patients. And as I mentioned before, this is a sexually transmitted disease. So the more sexual partners that you have, you are at higher risk for developing HPV positive tumors. The nice thing is that the survival is better. So when you look at HPV positive oropharynx cancers, overall, the survival is better in HPV compared to HPV negative. Now, when we do a little bit more of a drill down in these cancers, there's one specific point that I want to make. Now, we talked about HPV being a sexually transmitted disease. The other thing that I want to leave you with is that this HPV is an oncovirus. It is a true oncovirus. And when we look at the most common types of HPV that result in oropharyngeal cancer, there's the HPV 16 and the HPV 18. So there are over 120 subtypes of HPV, but the ones that put us at highest risk are going to be the 16 and the 18, of which the 16 is the most common type. Now, what ends up happening, again, I live in the world of head and neck, and so I don't know how much head and neck you all know, But those of you that are looking at head and neck and looking at these HPV positive tumors, you may have also heard of something called P16. And so what I want to emphasize is that unfortunately, just by the luck of the draw, you have the most common subtype of HPV being this P6, the HPV 16 subtype. But then you also have a protein that's called P16. These are completely separate. So what ends up happening is that, because of COVID, now we're all experts in PCR testing. The best way to detect that a oropharyngeal carcinoma that's due to HPV is to test with PCR, the polymerase chain reaction. That's the best way to test. But not all centers have the capability of doing PCR. So what ends up happening is that the pathologist can take the piece of tissue from the biopsy and they can actually stain it for a specific protein. And that specific protein is P16. So again, it's an unfortunate overlap. But when they stain it, this is a negative stain and this is a positive stain. So overexpression of the protein of P16 indicates by a high likelihood that this is probably a P16 positive patient, that it probably is due to HPV. And if that expression is greater than 75%, then we feel comfortable saying that, yes, this is an HPV positive tumor and can be treated. Now, there is at times a little bit of a false positive because other tumors, I should say other oncoviruses can express this protein. But if you will, this is probably what's commonly performed. And if there's any ambiguity, then you can go on to the standard polymerase chain reaction testing. The other thing that I want to focus on as we kind of delve into this is that we are going to be discussing a lot of anatomy. And all of you, I want you to all ask yourselves the question is that why do I have to learn this anatomy? Well, the greatest thing about head and neck for me is that 80% of what our referring physicians can see, that we see on imaging, can be either palpated or seen by the referring physician. So those of you that are on this call probably know that I see patients every Wednesday. So I'm well aware of what we can see at endoscopy and palpation. So if we are seeing a tumor such as this, and we say, well, there's a cancer here involving the tonsil here, and we'll come back to this tumor is involving the tongue base. If we just say there's a tongue base or a tonsillar carcinoma, I can see that. I can see it. I can feel it. But when we talk about tumors that are HPV positive in the oropharynx, realize from a treatment standpoint, these tumors can either be treated with surgery, which is transoral robotic surgery in most cases, or they can be treated with radiation and chemotherapy. Where we really make a difference, these patients, based on surgery or based on non-surgical organ preservation therapy, it's really up to us. Because I can tell you, when we see the patients in clinic and we think we have a sense of where these tumors are going, it's really up to us. So the point that I want to emphasize is that we can see the tumors clinically, but what I would like you to do is to become more familiar with the anatomy and start thinking about specific key elements, because if you just say squamous cell carcinoma, you really haven't helped. But when we start determining whether or not these tumors are going to be treated with surgery or non-surgery, the things that I like to include are, is there deep invasion of the muscles? Does the tumor cross the midline? Again, very simple from an imaging standpoint. Is there extension into the parapharyngeal space? We'll show an example of this. Are there any unresectable lymph nodes? I'm sure in the future we'll have a talk on lymph nodes. Is there bone invasion? And generally, this is pretty rare for oropharynx cancers, but it's still something that I always include. Is there any evidence of retropharyngeal lymph node metastases? What's the relationship of the carotid artery? When TORS first came out, there was a surprisingly high incidence of carotid injuries because sometimes that carotid artery extended into the retropharyngeal space. And is there prevertebral fascia invasion? So we'll talk about all these. Now, I don't necessarily believe in standardized reports. Some people talk about standardized reports, but what I like to do is have these key elements, because if we have these key elements, then we're going to be in a better position to talk about different spread patterns. And you'll see this later as we continue through the talk. Well, the second most common tumor to involve the oropharynx is lymphoma. And so why do we have lymphoma involving the oropharynx? Well, we have to go back and understand the contributions by William von Waldeyer-Hartz. And I'm sure you've heard about Waldeyer's ring. Now, for the longest time, I thought Waldeyer's ring was seen on axial images. I remember as a resident back in the last century, my attendings pointing out in a cross-sectional imaging and say, well, there's Waldeyer's ring. And they were basically pointing back here at the tongue base. But it took me forever to realize that Waldheyer described this over 100 years ago. And you find this ring when you look in someone's mouth. So this ring of tissue is almost like a ring of fire, if you will. This inferior portion of this ring, which is comprised of lymphoid tissue, is located behind the tongue base, located in the region of the vallecula. You then have the two lateral aspects of this ring of tissue, which is located in the tonsils. We'll come back to that later. And then you have the superior portion of Waldeyer's ring, which is the lymphoid tissue in the nasopharynx, and we call that the nasopharyngeal adenoidal tissue. So when we look at the Waldeyer's ring, we're actually looking in someone's mouth, and we see this lymphoid tissue extending from the nasopharyngeal adenoids down here to the palatine tonsils, and then eventually down here into the tongue base. So when I am looking at tumors that are involving the oropharynx, number one, by far and away, is going to be squamous cell carcinoma that I just showed. And then number two is going to be lymphoma. And the reason is because of this inherent lymphoid tissue involving the region of the vallecula. Now, sometimes what happens, as I mentioned before, is that you have this lymphoid tissue. And if you look real closely, we see a bunch of pebbles. See how irregular this is on the tongue base? Well, what can happen is that this lingual tonsillar tissue can actually become inflamed. And when it becomes inflamed, you can have what we call lingual tonsillitis. So if you look at this MR scan, it's a T2 weighted MR scan, you see this huge mass right here, and you're like, what in the world is that? And this is a different patient. And in this patient, we see another mass that looks strikingly similar to what I showed before. Well, believe it or not, all of this is just inflamed lingual tonsils. This is what's referred to as lingual tonsillitis. And if you look in someone's mouth, this is what you may see, just very, very inflamed tonsils. So the issue comes up, you're looking at a neck CT or a neck MR, and you see something like this. What do you do in a situation like this? Well, I can tell you, I can't tell the difference. So what I end up doing, and I do it all the time, is I'll comment on this mass and say this can be evaluated with direct visualization and palpation, because someone can look in the mouth, they can see it, and they can palpate it. And I can tell you it's not the most pleasant thing for the patients, but in general, what you end up doing is sticking your finger all the way in the back of the mouth, past the tongue base, and pressing down on the tongue base and the vallecula. And if it's soft, then it's likely lingual tonsillitis, and you can see that in endoscopy. But on the other hand, if it's firm, it's squamous cell carcinoma. So the bottom line is that we just can't tell, and it's completely appropriate to say, hey, I see something there. I'm not sure if it's tumor or whether it's tonsillitis. Let's go ahead and do just evaluate clinically. So this is another example here. These are two patients that have an abnormality involving the lingual tonsil. This one is squamous cell carcinoma. This is what it looks like clinically. And this is lingual tonsillitis. See how the inflammation, again, it's thickened, but this is what we see when we look at it on clinical evaluation. So again, hard to tell, but you can easily see it and palpate it in clinic. So the first tumor that we'll end up talking about is squamous cell carcinoma of the tongue base. That's the most common thing. Number two is going to be lymphoma. And the third most common tumor is going to be these little minor salivary gland rests, which result in minor salivary gland carcinomas. So it took me the longest time, but what exactly is a minor salivary gland? I wasn't very smart. I finally figured it out after 30 years. Well, if I have salivary tissue, it's typically seen in the major salivary gland. So that's the parotid gland, it's a sublingual gland, and it's a submandibular gland. They basically all have salivary tissues. Now, what ends up happening as you develop, you can have that same salivary tissue, but it sort of gets lost. It sort of says, hey, oops, I forgot. I was supposed to go to the parotid gland. Instead of turning right, I turned left. And lo and behold, there's certain parts of the head and neck that have a higher concentration of salivary gland tissue. And if you have a tumor that ends up arising in a rest of salivary gland tissue that is not in a major salivary gland, then that's what we call a minor salivary gland. And if it develops a tumor, that's why we call it a minor salivary gland tumor. So one of the areas that you have a high concentration is going to be not only in the oral tongue, but also in the tongue base. So the third most common tumor to involve the tongue base are going to be these minor salivary gland tumors. So this is an example of an adenoid cystic carcinoma involving the tongue base, and this is an example of another one, which is a polymorphous adenocarcinoma. Is there any way I can tell the difference between these two? Absolutely not. The only thing that I've learned over time that I can suggest the diagnosis, and that's because I'm actually in clinic, is that radiologically I can't tell the difference. But if I see a large mass like this, and then we look at the patient, and the mucosa is normal, or maybe there's a little bulge under the mucosa, but the mucosa is normal, then we can suggest that this may be a minor salivary gland origin because these minor salivary gland tumors are very, very deep. So that's the only tip that I can give you to try to diagnose these prospectively, because essentially everything can look like anything when it comes to these imaging findings. So what about other things that can arise in the pharynx? So we talked about this area right here, which is the foramen cecum. And in the foramen cecum starts the origin of the thyroid gland. So what happens with the thyroid gland is that you have this inferior descent that has this complex relationship to the hyoid bone, and eventually the thyroid gland ends down here in its normal resting place. But what can end up happening is that if you end up having remnants of that thyroid gland that don't normally descend, or it can leave little droplets along the way, then you have what I referred to as congenital thyroid remnants. And again, the terminology can be confusing, so I'm just going to tell you how I kind of look at this. So when I look at these congenital thyroid remnants, if I see a cyst, then I'll call it a thyroglossal duct cyst. So if I see a cyst that's located at the junction of the tongue base right here, right at foramen cecum, and notice how it's anterior to the genioglossus muscles, this is right dead midline into the tongue base, then I'm going to call that a thyroglossal duct cyst. And the reason it's important to mention this in particular is that the type of surgery that's performed to remove a thyroglossal duct cyst is a classic cyst drug procedure. So what the surgeons do is that they actually take this surgical incision and they always take a cuff of the tongue base because they know that the thyroid gland originates there. So if they're going to have droplets somewhere along the course, they also know that they also may have some remnants that are still located right at the foramen cecum. So if you have something that's cyst, that's fluid producing, you're going to call it a thyroglossal duct cyst. But if you have something that's solid, then it is still a remnant of the thyroid gland, but this is what we refer to as a lingual thyroid. So this is a non-contrast CT demonstrating lingual thyroid tissue here right at the foramen cecum. The reason why it's increased attenuation in the non-contrast study is because it concentrates iodine. We know that the thyroid gland is vascular. We all know this. When we look at a neck CT or neck MR, we know it enhances. And this is an example of a lingual thyroid. So this thyroid gland never descended. It's located right at the foramen cecum. It never descended, and we can see the avidly enhancing mass. Radiologically, when you first look at this, you're probably going to think it's a tumor, but you always have to try to discipline yourself to look down at the thyroid gland and notice how there's no thyroid tissue at all. So what this is that this is lingual thyroid. Now, one day, a couple of years ago, there was a patient that walked in with a lingual thyroid. That thyroid was right. In fact, I think it was this patient was located right at the foramen cecum. And so luckily, the very clever ENT surgeon was able to say, hey, this is not a tumor. I think it's a lingual thyroid because when it does pooch out like this, it can have a characteristic clinical appearance. But on radiology alone, that's probably not going to be our first choice. So please discipline yourself to look down at the thyroid bed. So that's our journey through the tongue base. And now what we're going to do is we're going to talk about the tonsil. So when we talk about the tonsil, there's actually three components of the tonsil. The main part of the tonsil is this area right here that contains the lymphoid tissue. So this is part of Waldeyer's ring. And this has a couple of names to it. It's called the fascial or the palatine tonsil. Now, when you look in someone's mouth, what you end up seeing are the tonsillar folds. So you have an anterior tonsillar fold that's located here, and then you have a posterior tonsillar fold, which is located posterior to it. And we're going to talk about this anatomy on the next slide. But what I do want to point out is that when you look deep to the tonsil, you're going to have this little muscle right here. This is the superior constrictor muscle. Then you have the buccinator muscle, and where the superior constrictor and the buccinator muscle interdigitate is the pterygomandibular raphe. The other applied anatomy I want to talk to you about is that when you see this fold of tissue, this is what we call the anterior tonsillar pillar. It's also formed by the palatoglossus muscle. So what muscle goes from the palate to the lateral aspect of the tongue? That's the palatoglossus muscle. Now, just anterior to the palatoglossus muscle, which is in the oropharynx, is this space that's located behind the last molar tooth, and this is called the retromolar trigone. This is the oral cavity. So realize this anterior tonsillar pillar separates the oropharynx from that oral cavity, and you'll see why that's important in just a jiffy. So this is an example of a tumor that's involving the anterior tonsillar pillar. So notice how this tumor is not located in the center of the tonsil, rather it's located along the anterior margin of the tonsil. And notice how it's growing anterolaterally. So you can actually see it's growing along the superior constrictor muscle towards the buccinator muscle. And it's also involving the expected location of the pterygomandibular raphe, or excuse me, the retromolar trigone. But why do I emphasize this? From a clinical standpoint, we know that the majority of oropharynx cancers are going to be HPV positive. So they can potentially be treated with chemotherapy and radiation therapy and have a good response. But on the other hand, we know that oral cavity cancers are going to be HPV negative. So from my standpoint, anytime that I see a tumor that's involved in the anterior portion of the tonsil that the surgeon says, yes, I think it's oropharynx. But then I look at the CT scan, I said, hey, hold on for a second. This is growing anteriorly into the region of the retromolar trigone and towards the raphe. It is very possible that this could also be HPV negative. So it's really important to identify in these areas, specifically identify where they are, and also recommend testing for HPV, because I always refer to this as the transition zone. But this is the classical example of an anterior tonsillar pillar carcinoma. And remember, the anterior tonsillar pillar is formed by the palatoglossus muscle. Now, this fold of tissue, which is posteriorly, we can see the white arrow. This is the posterior tonsillar pillar. And this white arrow points at this muscle, which goes from the palate to the pharynx. Are going to be tumors involving the palatine or the fascial tonsils. So this is an example of how confusing it can be at times. Remember, when we talk about Waldeyer's ring, remember that ring of tissue that we talked about? We talked about the pillars. So this is an example of lymphoid hypertrophy involving the tonsil. So this is basically big chunky tonsils. It doesn't necessarily mean it's tonsillitis. It just means that there's tonsillar hypertrophy, and this is just a normal finding. So this is just a normal appearance of nice, big, chunky lymphoid tonsils. Now, this is an example of squamous cell carcinoma. So here's an example of a squamous cell carcinoma involving the tonsil. Now, you're going to look at this, and you may even get a history, and you could say, well, there's squamous cell carcinoma involving the tonsils. But again, what I want you to do is kind of take it to the next level. Because if you just say that there's a cancer, they know it's there. But think like the surgeon thinks. The surgeon is going to say, aha, I have a tumor. Should I treat this with surgery? Or should I treat these patients with chemotherapy and radiation therapy? And remember, it's us. It's us, the radiologists, that's going to make a difference. So notice in this particular situation, what we have here is this tumor that's extending laterally through the superior constrictor muscle, and it's actually abutting the medial pterygoid muscle. Now, different surgeons and different institutions have different approaches as this. The main thing is to identify this type of spread pattern. So here's another example here. This is a patient that has a tumor involving the tonsillar squamous cell carcinoma. Here's another example of a squamous cell carcinoma involving the tonsil. What's the difference here? From you, the radiologist can say, hey, this tumor is extending medially, so this is an exophytic tumor extending into the airway. That tells the surgeon one thing without deep extension. But look at this one. Here's a tumor involving the tonsil. Look what it's doing to the parapharyngeal space. Instead of the triangular space, it's narrowing it. Now it looks like a rhomboid. Look at the fat planes here. Notice this tumor is extending anteriorly. It's abutting here, the medial portion of the medial pterygoid muscle. And with the leap of the faith, you can see my tiger stripe. See this black stripe here? See this gray stripe right here? Notice how the tiger stripes here on the left are gone. So those are the pieces of information that I include in my report, because now, at least at our institution, if I tell our surgeons that this tumor is growing anteriorly along the superior constrictor muscle, if I tell them there's a lot of deep extension in the parapharyngeal space and it's abutting the pterygoid muscle, oftentimes that's going to switch those patients from a surgical treatment to non-surgical organ preservation therapy. So again, very, very important that we try to do the best we can to identify the spread of these various tumors. Now, the other thing that I want to leave you with for the tonsils is that both of these have an abnormality involving the tonsils. This patient has a mass right here involving the left tonsil, and this is the case that I just showed, another mass. Well, when you look at this, it looks exactly the same. In this case, the patient had a right-sided tonsillectomy, and this is residual lymphoid tissue on the left. But on the other hand, look right here. This patient has an exophytic tonsillar carcinoma. It looks exactly the same. So what do I do in situations like this? Well, I just say, I see asymmetrical soft tissue involving the left tonsil. Just look in the mouth and palpate the tonsil, and you'll be able to make that differentiation. So if I'm ever stuck on this, I just include in my report, just correlate with direct visualization and palpation, because you can see that appearance can be confusing. The second most common tumor to involve the tonsil is going to be lymphoma. Radiologically, we really cannot tell the difference. So here's a mass right here involving the left tonsil. And if this could be squamous cell carcinoma, it could be lymphoma. But how can I suggest? Well, if I look in the neck and I see all these cannonballs in the neck, well, this has a typical bland appearance of a lymphoma. So if I see something like this and combine it like this, then I can say, yeah, this is probably a lymphoma. But again, our surgeons can look in and they can absolutely see what's going on. Now, what about some infections involving the tonsils? Well, this was kind of interesting. This was a case that I saw about 2 years ago. This patient came into the clinic, and someone, a very astute radiologist, picked up this mass right here involving the right tonsil. We examined the patient. The mucosa was completely normal. There was no palpable mass. The patient had a little bit of a low-grade fever, but was not really, really sick, and was a little bit inflamed. And so we thought, this just does not look like a tumor. So we put the patient on antibiotics, and lo and behold, about 6 weeks later, they ended up having an MR scan, and we can see how all of this thickening right here completely resolved. So again, when you see situations like this, it can be a little bit confusing. And in this case, this happened to be acute tonsillitis that ended up resolving. And this was just an example of a regular tonsillitis, if you will. But more importantly, you're going to see situations like this. So this was a patient that comes in with an infection. It's involving the right tonsil. What we see here is a mass of fluid collection involving the right tonsil. And there's another fluid collection here, which is sort of in this same region. I use the term peritonsillar and tonsillar abscess interchangeably. I've talked to the last 30 years, I've seen radiologists, I've seen ENT surgeons combine these terms. So for me, any type of abscess that's located within the tonsillar fossa is going to be peritonsillar. And why that's important to properly locate this is that if you say it's in the tonsil, then this can be drained intraorally. But on the other hand, if this is in the parapharyngeal space, that's important for you to remember, because this was a case I saw about 30 years ago at UNC. And I remember this, just a brilliant resident had initially called this in the tonsil. A little 2-year-old, they stuck the needle in multiple times and couldn't get it. The next day, they brought it into us. We say, well, this is not involved in the tonsil, but rather it's in the parapharyngeal space. So that day, they took the patient to the operating room, and they ended up draining this. So when we are looking at this tonsillar region, it's important to identify these fluid collections to determine whether they're in the tonsil or the tonsillar bed, because that indicates a intraoral drainage as opposed to whether it's in the parapharyngeal space. And this really requires a cervical drainage if they want to try to specifically do an incision and drainage on it. Now, these are just examples of chronic infections, and they can sort of look kind of ugly. So instead of being an acute infection, this is a chronic infection, and then you can end up getting these little calcium deposits, and these are what we call tonsillates. So these are bilateral tonsillates. You can see it sort of has this ugly appearance. We see this sort of all the time. That's just chronic inflammation. So they can be bilateral, or they actually can be multiple, as we see it here. And just remember, you can have other pathologies sort of give you abnormality involving the tonsil region. This was a patient that got kicked by a horse. Don't ask me how he got kicked by a horse. I sort of feel bad for him, but we can see the hematoma here. And then when we look at the tonsil, we can see the thickening of the tonsil, all of this induration involved in the parapharyngeal space. And we can also see the soft tissue inflammation as well. Well, we can have some congenital and developmental lesions. I think in the future we may have a talk on peds head and neck if you want, Akshay, at some point. But I do want to mention how this can affect the tonsils. So I think everyone is going to pick this out. So this is a second branchial cleft cyst. This is the classic second branchial cleft cyst. Remember, these arise from the second branchial cleft. But when you go back and read the literature, there's actually 4 types of second branchial cleft cysts. And the reason why I specifically mention this is that when I was a resident in Boston Children's Hospital, I was always taught that branchial cleft cysts involving the tonsil were always these little fistulas. But then when I went to my neuroradiology rotation, I was always taught that this was a second branchial cleft cyst. So it was kind of confusing to me. But when I went back and I read the original paper by Bailey, who described this, I think in the 1914, I believe was the paper, these different types of branchial cleft cysts have different manifestations on imaging, and we can actually see this. So this is an example of a fistula that's extending from the tonsil into the lateral aspect of the soft tissue. And when you look at Bailey's paper, you can see how this has a fistula that extends from the region of the esophagus and extends through the plane of the internal and the external carotid artery. So this is a type 3 second branchial cleft cyst. This is the classic type 2 second branchial cleft cyst, but this is a type 3. And this was another example. I remember I saw this case. I was completely flabbergasted. I didn't know what it was. I thought it was going to be metastatic thyroid cancer. But Ashok, you guys know Ashok. Ashok was junior faculty at the time when I was at University of Michigan, Srinivasan. He said, is it possible this could be a type 4 branchial cleft cyst? And I said, it could be. And lo and behold, he was right. It turned out that this was a type 4 second branchial cleft cyst. It wasn't a tonsillar cyst, but it was a type 4. So my point is that sometimes these turn out to be tonsillar cysts if they're actually in the tonsil. But just realize when you see something like this, oftentimes they don't present. In the back of your mind, you have to also consider a type 4 second branchial cleft cyst. Well, we're now going to move on to the soft palate. And I think everyone's kind of familiar with the soft palate. We gave a little bit of this before. When I think of the palate, I think of the palatal arch. So you have a palatal arch, as we see here, and the palatal arch is tethered to the skull base by 2 particular muscles. And those muscles are this muscle laterally, which is the tensor veli palatini, and then you have a muscle here, which is the levator veli palatini. So when I think of the soft palate, I think of the tonsillar pillars. And in a way that sort of looks, those are the lateral parts of Waldeyer's ring. So there's one tonsillar pillar, there's the other tonsillar pillar. And then the tonsillar pillars are connected, and they're connected by the soft palate. So how's that soft palate connected to the skull base, as we see in this Roman temple? It's through those 2 muscles. Again, the lateral one is the tensor, and the medial one is the levator veli palatini muscle. So when we look at tumors that are involving this soft palate, the most common is going to be squamous cell carcinoma. So I want to draw your attention to this one. This is an example of squamous cell carcinoma. And sometimes it can be hard to see because the soft palate is a midline structure. And when these tumors get really big, they can actually narrow the airway as is seen here. So the best way to look at these soft palate carcinomas is look at it on the sagittal images. So what we see here is a squamous cell carcinoma, again, very easily seen. And we have to remember that these squamous cell carcinomas can also involve the retropharyngeal lymph nodes. So when you are looking at these squamous cell carcinoma of the soft palate, remember, always look at these retropharyngeal lymph nodes. And again, we'll probably have a lecture on that as we continue this series. So what I do want to point out, though, is that if you do have a patient, this was a patient we saw in clinic probably about 2 years ago, had this huge mass involving the soft palate. In fact, it was a big exophytic mass. So obviously we could see the soft palate mass, right? We could see that. But the surgeon was trying to figure out, hey, do I resect this or do I need to treat it with chemotherapy and radiation therapy? So obviously he can see the mass looking at him. But what we need to be able to do is remember these soft palate cancers can grow along the upper surface of the soft palate and extend to the nasopharynx. So in this particular case, if I draw a line down the middle, the normal anatomy here is the eustachian, the torus tubarius, the opening of the eustachian tube, and the fossa of Rosenmuller. Look at the left side. See that torus is so big right here? This is actually superior extension of the squamous cell carcinoma into the nasopharynx. And when we see this, this is a contraindication for surgical treatment of squamous cell carcinomas involving the soft palate at most institutions. And I can tell you, this is really hard to see at endoscopy. This is where we really make our money, if you will. So when you are looking at soft palate cancers, always look at the nasopharynx to see if there's superior extension. The second most common tumor to involve the soft palate are going to be the minor salivary gland tumors. And again, as I mentioned before, you can get these little rests of tissue. So when you have these minor salivary gland tumors that can arise in the soft palate, you can get these pleomorphic adenomas, and in this case, it's adenoid cystic. Sometimes with pleomorphic adenomas, we can suggest the diagnosis. They tend to be high signal on T2. So if I see a mass involved in the soft palate and it's high signal on T2, it enhances with contrast. Yes, it could be squamous cell carcinoma. It's probably not going to be lymphoma, but if it does have that high T2 signal, then I do raise the possibility of a pleomorphic adenoma. And then you can have a variety of developmental lesions. This is a lesion that has high T1 signal involved in the soft palate. This happened to be a dermoid. You can have these areas of increased T2 signal that are transspatial. This happens to be a vascular malformation, in particular a lymphatic malformation. And remember, the most common soft tissue malignancy to involve a child in the head and neck is going to be rhabdomyosarcoma. So I don't try to subdivide this into embryonal or alveolar or pleomorphic or some type of spindle cell. I just say it's a rhabdomyosarcoma, and I let the pathologists and genetics folks tell me exactly what type it is. And then the last area that we're going to cover is the posterior pharyngeal wall. Now, there's not a lot of pathology that involves the posterior pharyngeal wall. We've already talked about it already. So really, we spent a lot of time going over the tongue base, the tonsil, anterior tonsillar pillar, posterior tonsillar pillar, palatine tonsil, and now we're going to talk about the posterior pharyngeal wall. The posterior pharyngeal wall of the oropharynx has two primary components. It's the superior constrictor muscle and more inferiorly, the middle constrictor muscle. So when we look at tumors involving the posterior pharyngeal wall, the most common is going to be squamous cell carcinoma, just like any other place in the head and neck. It's going to be squamous cell carcinoma is the most common tumor to involve that posterior pharyngeal wall. Now, 9 times out of 10, the surgeons can go in and they can see this posterior pharyngeal wall tumor. But what they need for us is that we need to be able to describe the extent of it, and then also think like the surgeon thinks. The surgeon sees this mass right here, and they want to know whether it's resectable. Should they treat it with surgery or should they treat it with chemotherapy and radiation therapy? What's the information that we can provide? Well, one of those is to whether or not there's invasion of this fascial layer. Now, this fascial layer has different names to it. It's changed its name 3 times since I've been alive. I still call it the prevertebral fascia. Some people will call it the perivertebral fascia. Some people call it the paravertebral fascia. Whatever you want to call it, it's fine. So long as you know where it's located and what it encompasses, that's great. So if this tumor is not invading the fascia, then it's still potentially surgically resectable. But if invades the fascia, then it's a contraindication. So how do we identify that? Well, here's a large tumor involving the posterior and the lateral pharyngeal wall. And what this white arrow shows on the T2 weighted images is edema in the longest coli muscle. Notice how it's not here on this other